Hi, everybody. My apologies. We actually had a very vibrant meeting this morning with those who joined via Zoom, but it's my own fault. I had paused the recording while I was waiting for people to join, and I didn't bother restarting it. And about 90% of the way through, when we were almost done, uh, I realized that I hadn't been recording the meeting. So, unfortunately, uh, this is the best that you're going to get. It's just going to be me talking, but I'll try and go through as much as what we went through this morning as well. But of course, there may be some parts missing, and my apologies for that. So we're going to talk about an ECG, and we're going to analyze it. So the first thing that we're going to always do, we always remind ourselves of what we do when we are analyzing an ECG. We analyze the axis. Let me just get my laser pointer up. Sorry about that. So we analyze our axis, we analyze our rhythm by looking at the P waves, the PR interval, whether our QRS are narrow or wide. Do we have a QRS after every P and regular groupings of P QRS? We analyze the rate, we analyze each zone, and this is our ECG. We're going to get to the big one just now, and then we're going to see from there. So the first thing is we've got an 82-year-old man who presents after a syncopal episode with a blood pressure of 70/35. And the first thing that I asked everybody was, what would you consider as your differences? Let's say you were lying in the restroom, having a bit of a nap, and the nurses were to call you and say, listen, we've got a guy, 82 years old, who's just come in after syncopal episodes, blood pressure is 70/35. So we know that he's in shock. So we try to go through what could be the possible causes. Somebody has had a syncopal episode, and people came with some wonderful answers. So the first thing you would consider is hypovolemic shock. So you would think about maybe a dissecting aortic aneurysm, especially if it's associated with the chest. Um, Obstructive shock, if the patient has a pulmonary embolism, which is common in elderly people, they embolize from a lot of areas. Then we thought about cardiogenic shock, which would be anything related to ischemia, rhythm disturbances, electrolytes, things like that. And then we had thought, okay, what about sepsis? It is possible. Septic shock would also lead to such a thing. You've got an 82-year-old, subclinical infection can definitely cause problems as well. And of course, the last one is neurogenic shock. Now, even though we don't have a history here, but I mean, a patient, 82-year-old, falling, frail, we don't know what he's injured. It may be possible that he's got a spinal injury, and because of that, he's unable to keep his BPs up. But that was just a little exercise to talk about shock. The most important thing now is that we've got the ECG in front of us. And the first thing that we notice is we've got a very slow heart rate, even though it's not the place to begin, but it's the first thing that strikes you out of nowhere. I mean, we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 blocks between R complexes or S complexes or Q waves. So we've got a rate of about 25. So this is an extreme bradycardia. And the thing is, as your bradycardia becomes more extreme, it tells you that the heart is being stimulated from lower and lower and lower down the electrical pathway. So you've got your SA node, your AV node, your Purkinje fibers, your bundles of His Purkinje fibers. So, as you get lower and lower and lower, the rate gets lower and lower and lower because each of them is less effective as a pacemaker cell and can only stimulate certain parts of the ventricle as well. So your ability of your ventricle to contract actually decreases. So force is decreased and things like that. Now, the other thing, let's look at the axis first. So let's do a little drawing. Let's do our drawing over there. Let's try and get it in a nice bright shade. And let's get a nice line. So for those of you who remember, just put, that's fine too. So we can just put our little line like that. So we've got lead 1 over here. And let's just put an X over here for lead AVF. All right. And then we say lead 1 is pointing upwards. So we know that the axis is either there or there. We know that it can't be here in the extreme right or in the right. And then we look at lead AVF, which is negative. So that means electricity is moving away from it, can never be moving towards it. So that only leaves us with one little option. So that means we've got a left-sided axis. All right. So that was the first thing. Now, the more important thing, let's look at the rhythm. All right, so we know we've got a bradycardia with the left-sided axis. So this tells us that either something's happened on the right-hand side, so all the electricity shunted to the left, or that the left side has become larger. Okay, but anyway, let's have a look. So the first thing we do is let's analyze our P waves. Let me just clear this up, sorry. So let's analyze our P waves. Let's look at them and let's see what we have. So the first thing we notice in our rhythm strip is that we do have P waves. We can see them here. They may not be the most morphologically correct because they're a bit flattened, they're a bit wideish, but I mean, this is a heart that's under strain, but we do have P waves, that's for sure. And we can't talk about the PR interval because look, the PR interval has nothing to do with what's going on. It just keeps on changing. It's irregular completely. There's no regularity to that PR interval whatsoever. Does a QRS follow every P? No. You can see there's a lot of QRS complexes that are missing. So there's a lot that are going off over there. And then what about the QRS complexes themselves? So we know the QRSs are wide. And we had already spoken about this, that we said when you have a wide ventricular complex, QRS complex, it means that your impulse is coming from further down. So in this case, it's coming from quite low down. That's why you're having this wide complex everywhere, right? And then are they regular? Now, that's an interesting question, and we're going to get back to that now. It looks relatively irregular, but we'll get back to it now. Let's look at each zone. So the first thing we notice is in leads 2, 3, and AVF, we have what look like Q waves. All right, so these are little Q waves. So that tells us that ischemia has happened. It just doesn't tell us when. Could have been a long time ago, could have been now. And especially with somebody who's got a third-degree block, they could have been sick for quite some time, maybe just not even realized it, and been slowly but surely progressing and getting worse and worse. Just hide this for a second. All right. So if we look at V1, in V1 we've got a Q wave. This is the septum now, remember that we're looking at. In V2, you could argue that this is a little R wave, but maybe it isn't. So, let's just say V1 and V2 look like they've also got Q waves. But more importantly, we start seeing inverted T waves. And then we see in V3, V4, the septum, that even though we've got these deep S waves, the more important thing is that we've got these inverted T waves. Now remember, inverted T waves are non-specific, completely non-specific, but in certain settings, they need to start getting you thinking about ischemia. So in this case, it keeps on getting, it continues to tell us that this could be an ischemic event. In V5 and V6, we don't have the best view of the QRS complexes, but what we can see is that we've got maybe a little block over there that's going on. Again, the inverted T waves. And then when we come on to the high lateral leads, 1 and AVL, we notice these flattened, very shallow T waves with wide QRS complexes, and in AVR as well. So we suspect there may have been an ischemic event over here. That's the thing. So the thing is, what could be contributing to this ischemia as well is this blood pressure and the low heart rate. So remember, the heart is dependent on itself for its own blood supply. So your heart pumps, the blood goes up. When the blood comes back in diastole, it falls down the aorta. You can imagine the aorta as a pipe. That's when it flows into the coronary arteries. So you've got a slow heart that's not pumping out a lot of blood. So the blood that it pumps out is very little. So very little comes back. And that very little that's coming back is not coming back very often. So when you have these situations, these patients' ischemic status becomes much worse, much more quickly, and can sometimes also trigger the entire thing off. Okay, so that's something to remember as well. Okay, so that may also be, like I say, aggravating the ischemia. But now the thing that I want to get to, here we have an atrium that's pumping, all right? So we can see the atrium. And if you actually look at the atrial impulses, they are relatively regular. In fact, they're about 3 blocks away from one another. So you've got this atrium that's going at about 100 beats per minute, and you've got this ventricle that's going at about 25 beats per minute. So I'm going to do what I did for the guys earlier, in that we're going to make a little drawing, all right, just to demonstrate some things. So let's create a little atrium over here. All right, so there's our little atrium over there. And then let's create our little ventricle. All right, so of course this is just a drawing, remember that, okay. And then let's put something here. Then we've got our atrioventricular septum that's running across. And yeah, let's put our nodes, all right. So we've got a little SA node over there that pumps down to the AV node. Let's put it, well, the right-hand side would be there. Let's not get technical, but that's the AV node. Let's change the colors of these now. And then you start getting all of your fibers that go off and your fascicles, and it goes to the right and the left and everything, and supplies the entire heart. All right. So let's look at what we have. And normally what would happen is that you would actually get, sorry, just get this right over here. So normally what would happen is you would get your impulse going from your AV node, SA node to your AV node, and then it would be passed along wherever it needs to, all right? So we've got an atrium that's functioning, and we've got a ventricle that's functioning. And we've got a ventricle that is now functioning almost without any input from this atrium. So this atrium is going at 100 beats per minute, and this ventricle is going at 25 beats per minute. So what do you think is happening here at the septum? Because remember, the electricity has to pass through that septum, that atrioventricular septum, in order to get to the AV node. We're not being specific. I mean, this is not an anatomical drawing. We're just saying, all right. So what type of a block do you think this is if there's no association between the atrium and ventricular function? And if you said a complete heart block, you are 100% correct. What it means is that whatever damage has taken place over here is now causing no electrical impulses to pass through, all right? So this is what a third-degree heart block looks like. Now, in a first-degree heart block, what you've got is that you've got a what you call a bit of damage, but it can still bypass and get around over there, or it can come from the junction. It's just that it takes a bit longer. That's where the PR interval is involved, all right? With Mobitz type 1 and Mobitz type 2, with Mobitz type 1 also there's damage, but again, it can find its way around, find its way around, find its way around, until eventually it can't find its way around, and then it starts. It's a simplistic way of looking at it. I mean, it's much more complex than that, but that's just to let you know. And then with Mobitz type 2, there's damage, and it takes a very long time for everything to get through to the AV node, and eventually you don't get an impulse pass through. But if you are interested, it's worth it to go and read the pathophys, but that's a lecture on its own, okay? So what we have here is that there's no connection between the SA node and the AV node. So it means, you know, this is a third-degree heart block, all right? So let's have a look and see how close we were to everything, and with some ischemic changes as well. Move on to the next one. So we have so ST stands for sinus tachycardia. Now, for those of you who had listened to previous lectures, you may wonder, but this is definitely not a sinus tachycardia. Actually, when we are being technical, when your atrium are functional and your atrium are consistent, then we call that a sinus activity. So an overall rhythm strip would be called a sinus rhythm strip. But in these technical books, or the more advanced books, we actually just look at the atrium to decide if it's a sinus tachycardia or ventricular tachycardia, ventricular brady. In this case, it's a sinus tachycardia because the sinus is going at 100 beats per minute. Okay, so just to clear up some confusion. With AV dissociation and third-degree AV block. Now, we spent a lot of time talking about this morning, and we're going to get into it now, because I don't know about you guys, but when I was at varsity, when they started talking about things like AV dissociation, third-degree AV block, I just switched off because I was like, geez, this sounds boring, and it doesn't sound like something I'll ever be able to get into my head, but I'm going to teach you guys about it just now, right? Ventricular escape rhythms, what that refers to is that the atrium is functioning, but because nothing's getting through to the ventricle has to pump on its own. So when a ventricle pumps on its own without any other input, that's called an escape rhythm. So basically an escape beat. An escape beat is to keep the person alive, right? So you can have atrial escapes, but more commonly is ventricular escapes. T-wave abnormality is consistent with anterior ischemia, which is what we saw, and non-specific T-wave flattening and inferior leads. They don't talk too much about the Q waves, but it is something that we should consider. So I'm going to go through this next part quickly. And if you're anything like me many years ago, you would lose interest after a minute. I don't blame you. So we're going to get into how you actually talk about the two. So ECG criteria for third degree AV block or complete heart block are present. These are the evidence of independent atrioventricular activity. The atrial rate is 100, the ventricular rate is 25. The PR intervals vary randomly, and there is no evidence that any of the P waves are conducted to the ventricles. Okay. Occasionally, AV dissociation, independent atrial and ventricular activity may exist in the absence of complete heart block. In these cases, there will be ECG evidence of some P waves conducted to the ventricle. So if you're anything like me, even while I was reading it, I switched off. So let's talk about what it actually is. So what is AV dissociation versus third degree complete block? Because they are very similar. So atrioventricular dissociation is not only due to a third degree heart block. Okay, but to have a third degree heart block, you must have AV dissociation, all right? Basically, for both of them, there's no correlation between the atrial activity and ventricular activity. So the atriums function independently and the ventricles function independently, all right? The difference being that if you have AV dissociation, you may have an occasional atrial discharge or junctional discharge that is conducted to the ventricle. All right. Whereas in third degree, you never have atrial activity passed on to the ventricle. It's the end point of Mobert's type 1 and type 2. So this means you would have to run a rhythm strip for quite some time, maybe even 10, 15, 20 minutes. If you go to a cardiologist, they'll give you this old machine. Some of you guys may know what cassette tapes are, giving away my age, but they still have these things amazingly. At least recently when I took a family member, they still gave her that. It's a machine that does a 24-hour ECG rhythm check, and it records it on a cassette tape. And basically what it does is it looks for these occasional P waves that are connected to ventricular impulses. So you have this P wave with a narrow QRS complex. So the question is, what does it have to do with us in the emergency department? And the answer is it has absolutely nothing to do with us in the emergency department. The only advantage for you to be able to say it's AV dissociation versus third degree complete block is that the physician will give you a round of applause, and that's about it. It's not like if you tell your patient they've got AV dissociation, that they will get up, shake your hand, and walk away. It actually makes no difference to our management of the patient because the two are so intricately linked, and it normally takes quite some time to actually differentiate between the two. The only difference is that AV dissociation may be associated with certain chemical imbalances, electrolyte imbalances, a direct trauma. There's a few things that may be dealing with it. However, third degree complete block is a type of AV dissociation. Let's put it that way. Okay. Or let's say it's a complete AV dissociation. Let's put it that way. Okay. But don't stress yourself out about it. So generally in a third degree block, you have wide complexes. In an AV dissociation, you can get occasional narrow complexes if they are junctional escapes or atrial captures. All right. Why we say generally, there have been reports of occasional narrow third degree heart blocks, but I haven't seen any. I remember reading about it in one piece of literature, but I've never actually seen one. By definition, it should be wide. Okay. So your patients with third degree heart block at high risk of syncope and cardiac arrest. The reason for this is that there's absolutely no association between that atrium and ventricle. So the ventricle is relying completely on itself. And as the damage goes lower and lower, like I say, there's lower heart output, there's lower cardiac output, and there's slower cardiac output. So you're getting less blood to your brain. Okay. All right. So what you call it, you're getting less blood to your brain less often. Okay. So the chances of syncope are much higher. Okay. And cardiac arrest, again, because of what we said happens to the heart and its own coronary supply. Okay. Now, however, in AV dissociation may not always happen because you may still get those atrial complexes that are going through, so you may still be able to. Okay. So both terms are often used interchangeably. And if you're unsure, always say it's a third degree rather than a complete block. Okay. It will save you from a lot of blushing. by instead of making a mistake. Okay, so at least I hope you guys got that bit of it, all right? So the management now we had covered previously, but it's always good to have this, what you call it, algorithm in mind. You look for causes, all right, but don't delay treatment, assist the patient as much as possible. Patient is unstable because of the low BP, the syncopal episode, things like that. All right. You establish your IV access and you try and get a return of spontaneous if the patient crashes. All right. Now we're going to just talk about atropine and all of these for a little while. So atropine, remember, it causes the increased rate of depolarization of the vagal nerve, and the vagal nerve supplies the SA node only. So the SA node, in other words, is the atrium. So it only helps in narrow complex bradycardias. Once you've got a wide complex bradycardia like what we have here, atropine is unlikely to help. So first degree heart block and Morbitz type 1, which we discussed last week, should respond to atropine. However, Morbitz type 2, if it's narrow complex, may, but it's unlikely that a third degree may, all right, or complete heart block will. You can use adrenaline, and this is the way that you use it. 1 amp in 200 mils crystalloid at 5 mils per hour can be increased to 10 mils per hour. We do go above this sometimes, there's no doubt, but it just depends on your patient's response. Okay, what happens with adrenaline? It will cause some inotropic increase, so increase in the force, and chronotropic, but it's not as helpful in third degree. That's the thing. In my experience, they do say that it does help, but I must be honest, it does very little, and patients often need very high doses. Okay, so we won't be discussing these right now. We'll discuss them later on. So these types of patients need urgent pacing. Now, that's the end of this particular lecture. Now, for those of you who maybe still are a bit confused about pacing and things like that, I would suggest go back to our meeting that we had on the 22nd of February, where we cover the entire thing, how you pace a patient. There's some videos on transcutaneous pacing. We did go through it this morning in the meeting. The video takes a bit of time, so I would suggest if you don't want to go through the entire entire lecture video, just go through the PowerPoint itself and just bring up the two videos so that you can see. But at the end of the day, what we are trying to do is get the patient's heart rate up. Most patients who have a complete heart block do require urgent pacing, normally in an ICU setting. But if you're in a district hospital, adrenaline will help you. If you have access to dobutamine, or any of those, Dobitrex, and it can help as well. But it's sort of much more fine-tuned, and you've got to make sure you've got an infuser, whereas adrenaline, you can still kind of run through a dialer flow and things that are more readily available at a district level. If you're at a regional hospital, however, you do have access to dopamine and all of these drugs, although they're normally in an ICU, and a regional hospital should have an ICU, which means that you can push the patient there. It's an easy drug to use, not difficult to use. It's just not generally available in the emergency department. So I hope you guys enjoyed that. My apologies to all those who took part this morning and their voices have not been on here, because we really had a nice discussion this morning. And I hope you guys enjoyed this one as well. On Wednesday, we will be talking a bit about ultrasounds, and I hope you guys will join me for that as well. Don't forget to hit like, subscribe, and share. No, I'm just joking. I just always wanted to say that. And yeah, I hope it was enjoyable for you guys. Okay, thanks a lot, and we're going to end it there, and I'll post this on the group. Thanks. Bye.